Welcome, everyone. My name is Dr. Benjamin Galen, and I am the editor-in-chief of POCUS Journal. I'm really excited today. We have our 8th podcast recording today. For those of you who don't know, POCUS Journal can be found online at POCUSjournal.com, and we are the world's leading free-to-publish in, free-to-read point-of-care ultrasound journal, and we're really lucky to be supported by our publisher, Synquil Medical Publishers, which is a nonprofit out of Queens in Canada, Queens College. And I'm really excited today because we have some very special guests who are going to introduce themselves. But the goal of today's podcast is really to discuss some of the background and implications of a study that came out in the November issue of POCUS Journal. The study is led by first author David Tierney, who's going to introduce himself shortly. The study is the association of internal medicine point-of-care ultrasound with length of stay, hospitalization costs, and formal imaging. And this is a prospective cohort study. So we have the internal medicine editorial board with Tanping Wong and Trevor Jensen here as well to join our discussion. But I'll let Dave introduce himself. For those of you who don't know him, Dave Tierney is a world leader and pioneer and a visionary in point-of-care ultrasound as a renowned clinician educator and program leader. So Dave, tell us a little bit about yourself.
Yeah, no, thanks for having me, Jamie. I've been doing point-of-care ultrasound since probably 2004, 2005, hidden underneath a white coat, just trying to sort it out. A long time ago, but I'm currently the internal medicine program director at Abbott Northwestern in Minneapolis, which is a huge hospital, which is the largest medical complex in the Twin Cities, but it's not a university setting. So it's a quaternary care setting, the flagship for a huge 12 hospital, 100-something clinic health system, the Alina Health System. So that's the setting where this happened, and that's the setting where I spend my career, which I think is important just to understand the hospital setting that this study took place in.
Awesome. Thank you, Dave. Tanping Wong, tell us about yourself.
Absolutely. So I'm currently at Weill Cornell in New York City. I've been here for about 8 years, working as a hospitalist. I'm part of a small group of very enthusiastic POCUS faculty. So I'm not here alone. And we have a pretty extensive POCUS program that includes a 5-day POCUS class that we run twice a year. We have a fellowship program. We run the resident elective and faculty development as well. But just to put this in context, I looked at Dave's study that started in 2011 and ended in 2015. And I think the first time I actually heard of the word POCUS is in 2016 at the completion of your study. So just catching up here, Dave.
Awesome. Thank you, Tanping. Trevor Jensen, also the co-internal medicine editor of POCUS Journal.
Thanks, Jamie, and thanks for having me here. Yeah, I'm Trevor Jensen. I am a hospitalist at UCSF and have really only been here in my medical career, been here for almost 20 years. And my involvement in POCUS, sort of all things I am POCUS here at UCSF. I direct POCUS for the DHM, the Division of Hospital Medicine here, where we have a good group of folks who work in research, training, and clinical use. I co-direct our internal medicine residency training for the IM residency program. And then I currently direct our hospitalist procedures service. So really excited to chat about this piece today with Dave and all of you and delve in a little bit to some of the first sort of outcomes research that we've had in this category.
Yeah, this is an incredible study. Those of you who are just joining in, POCUSjournal.com, you can find the study. It's on the website for free to read. We want to start by asking Dave a little bit about the background of this study. I know that the study period was 2011 to 2015, but the questions that you had, the idea for the study and the study design clearly took place long before that. So tell us sort of the origin of this, the team that you put together to help answer your question, and take it away.
Yeah, so the origin of this is, I mean, the IMBIS program. So kind of before POCUS was totally the acronym, right? We called this program here at Abbott IMBIS, which maybe is just a bad acronym, but it was the internal medicine bedside ultrasound program. And it started probably 2008, 2009, and then was really underway in 2010 as a resident training program in this residency program and faculty. The reason that the study timeframe was chosen, which seems like a strange 4 years to have chosen for this, is that we really thought about for a long time, how are we going to actually compare care with and without point of care ultrasound in a hospitalized patient setting? And there are all ideas around randomized trials and different ways of doing this. And I think we can talk a little bit about it, but I don't know that a randomized trial is the best way to study this. And we had a unique time period from 2011 to 2015, where the ability to use ultrasound in this hospital was only tied to presence of our resident teams on a patient because they physically had it on their shoulder. It was in a bag. There weren't any other machines up on the station. So the only way to get an ultrasound outside of the emergency room or the intensive care unit and our bedside procedure team was if there was a resident team taking care of a patient in this house. So it offered at least a little bit of a semi-randomized study design because those resident patients took care of a subset of our hospital admissions. And it was just a unique sort of strange, I don't know what to call it, but kind of a unique study period to be able to analyze this in what I think is actually a true sort of way, and maybe more true than randomizing the tool. So that study period was chosen for that. And it was also early in this program. And I guess part of this goal was to try to lay out for programs starting, what might this look like in the first 5 years or so after you start, not year 16 or whatever we are right now, but sort of the initial years when you're trying to make a case for system outcomes and why does this make sense as a system tool, not just at a patient level.
Got it. As far as the design, then was there any concern from I guess administration or the IRB about that design model or the time frame that was proposed in terms of support? That's a bunch of questions in a row, but this is clearly took a lot of work. Was this something you sought funding for devices, or the devices were already on the shoulders?
Yeah, the devices were in place here already. And we knew we were going to do something of this sort at the time. So everything from that time period was prospectively collected, which is important. All of the ultrasound exams that were done on every patient were prospectively collected. So we had all the data prospectively to be able to do this at the time. There were no IRB concerns around it. We had to make a case for safety, like many do with a piece of technology that wasn't totally under the IRB's mind as far as a in the hospital stethoscope-ish sort of tool that we carried around. So we had to make that safety case, but otherwise there wasn't concern from an IRB standpoint. The tools were in place. Yeah, and it was just the nuance of how do we want to structure this to try to get at the tool, right, as the variable and try to exclude all of the many, many, many confounders that can mess with this study.
Tanping, you have a question.
I mean, you let me know, Jamie, whether or not we should, you can direct questions. What would be a good time to jump in? Yeah. Dave, it's really amazing. I keep having to reread the word perspective several times to think that at the very beginning, you had some of these outcomes in mind and to have these questions in mind. That's actually just so much foresight, right? Now we are, another 10 years later, these outcomes are still incredibly relevant and important. And not only that, there aren't a lot of other outcomes data. So just kudos to you for having the foresight back in 2011 to ask some of these clinical questions. And I guess some of my questions for you is, it sounds like you were just starting to do this in 2008. and the study took place between 2011 and 15, and we're now in 2023. Can you sort of give me a sense of the evolution of your program over these years? Like, how did you get to where you were in 2011, where every resident had a machine, and not only that, have faculty that can oversee their scanning, and where are things now? Because I think in my mind, your program is what many programs across the country strive to become. And like, how do we get to where you are, and what are the key ingredients? Just and some insight into your development.
Sure. Yeah, so I'll say that I've been here at Abbott for 20 something years. And when I began this, I had a boss, Terry Rossborough, who is one of the authors on this paper, the second author. Terry was my boss. He is a master of traditional physical exam. He was the director of medical education. And he was also a master of interpreting skeptically the medical literature and test characteristics and the ability and inability of our traditional physical exam. All right. So I had a boss who was totally engaged in technology and was humble enough to understand that we could do better than we can with our hands and our stethoscope at the time. And none of this would have happened without that setting, first of all. It was a set then in a hospital that has a history of innovation and leading from a technology standpoint, and a hospital foundation that has supported medical education innovation for its entire time. So at the beginning, there was an environment. There was someone in leadership who was totally on board with this for all those reasons I just mentioned. And we took our core faculty first at Abbott. We trained 13 of our core faculty for a year and a half before we trained a single resident at this place, under the idea, which many people who talk to me about this know it's my 100% have to, which it's not 100%, but I firmly believe in training your faculty first, so that the residents, once they get trained, have faculty around them who totally are on board. And we did that for a year and a half. We trained our core faculty. After that, then we trained every resident class since 2010 in this. It's a week-long course at the start of residency, a couple months in, a hands-on course. And then we've got today a dedicated month on the procedure and ultrasound team, and then a dedicated month in an outpatient advanced ultrasound rotation. But every group of residents we've trained over the years, we've trained more faculty with them. And not just medicine, but outpatient primary care docs and cardiologists APPs. So it's always been a parallel faculty and resident training program, but it started with the faculty. And we could do the faculty, one, because Terry Rossborough said we're going to pay our faculty to learn, just like we would pay them for their time taking care of patients if they were doing that instead of this. That was a commitment on his part to do that. And quite honestly, that's a hurdle, right, for a lot of places and a lot of people. So we paid our faculty up front to learn this, and not just the course, but for the time they spent every month doing this at the bedside until they got good. That was all paid, and that was foundation money and just our department budget.
Incredible. Thank you so much, Dave, for dovetailing your discussion about the study period with the program and training. I know training's discussed a little bit in the methods section, but it's great to hear for our listeners to hear more about that. I think, Trevor, you had a follow-up question.
Yeah, I mean, I think it's so amazing to see this, happening at your institution, 10 years ago plus. And I think there's finally some additional traction at places like UCSF, where I work, over the past few years. And I think at a lot of institutions for now, sort of paying people and taking care of the resources they need to get training. But related to this, as you mentioned, you're now almost too late to study in real time, sort of two different cohorts, a with and without. But I'd say most folks are now just realizing that sort of with and without as they implement. Do you have any advice or pearls that others can use as a roadmap to do research on sort of this early implementation when it can seem so daunting, I think, to both implement and study it at the same time?
Yeah. Let me take a shot just at what is figure 1 in the paper, but I'll try to explain it podcast visually for you as well, because I think it gets at that, Trevor. And so there were 45,000 patients that came in during the study period to internal medicine. There's 2 sets of hospitalists here, one of which teach, so are teaching attendings, another group that does not. And we took the group of teaching attendings who got patients into the house. And those teaching attendings have some patients on resident teams when they're on a teaching week, if you will. And even within that week, if they've got 14 patients, maybe only 8 or 10 of them are on their resident team with them. And then they've got another week, 2 weeks from now, when they're not teaching and they're taking care of patients by themselves. All right, so we had a single group of hospitalists that both were with the residents, AKA in a teaching role and therefore ultrasound present. And we had that same exact group of hospitalists who, for a different set of patients, were without residents and therefore without POCUS. Okay. And in the end, we chose to compare patients by this single group of hospitalists who had ultrasound or didn't, rather than comparing patients who had ultrasound in this group with that other group of attendings who didn't take care of patients with residents, weren't teaching attendings, and never had ultrasound. And that was a choice based on what do we want to control for, right? In this, do we want to control for a bunch of different providers in the 2 groups and practice styles and all sorts of stuff? Or do we want to take that out of it and just say we got the same attendings that we're comparing to themselves, and then just try to correct for the presence of residents? And when you correct for the presence of residents, then you would be left just with ultrasound, right? Essentially. So that's this study design and why we chose the subgroups we did to compare. And I think it informs your question about in a setting, right? How do you figure out how to study this? And the other option, right? The option that some might say, this is what you should do if you were going to study it in your place, is let's randomize patients. They come in, this patient's either going to get ultrasound in their hospital stay or not. And when you do that, it introduces a tool that isn't useful for everyone. And you end up using a tool on people who you probably otherwise wouldn't have in some situations. And you then have to control for the providers, right, in the 2 groups, which is a super, as you can think of, right? The differences between all your partners, right? In a hospitalist group, we've got 100 and something hospitalists here. To try to control for that is just sort of impracticable. So I think the idea of how would you randomize this is difficult from that standpoint. And then 2, the question it's not necessarily ethical question, but it is, if you were going to study this in a way that people actually were good enough to show you outcomes. Okay, so providers had been trained to a high level to show you the outcomes that POCUS can have. Is it okay to take it away from those providers for a subset of patients, such that you were taking care of a patient and that one was randomized not to get this tool, right? And I can tell you quite honestly, right, that I can't percuss a spleen as well as I could 20 years ago. Okay. I can't do some of that stuff without ultrasound as well as I can, or I could, right, 20 years ago. So there's just a moral sort of equipoise question, right, that exists. If you're going to do this in a place where you could show the potential of it because you were good enough, could you actually take it away for a subset of patients? And that's at least, I think, an interesting question for people who are thinking about how should I study it? Could I randomize it? And if not, how can I set up a study that tries to minimize the complex confounders and hopefully leave you something simple-ish to correct for?
Absolutely. I mean, it's so great to hear how you put this together, the thought that went into it, the how careful you were about it. And I think when I hear about the possibility of randomization, I think that there are the strengths that you mentioned, but the trade-offs, this study has a kind of generalizability as a result of what you said, where the only factor that's being really controlled for is the presence of the ultrasound, as opposed to what you said, where randomization would have patients who didn't need POCUS, be undergo the procedure. So I think this design really is so strong to answer that question, the ones that you're asking, and not only that, it allows you to achieve really large numbers. I think you could do a small randomized trial or retrospective study, before I took an ultrasound course and after, but it's such a small number. And what strikes me, it's unusual in the POCUS literature to have this large of an N at any point, whether it's the number of patients or the number of users. It's really the sort of first of its kind in that regard. Tanping.
Was, Trevor, the question about implementation and studying at the same time, it's very challenging, right? As many new programs, I think a lot of us are just caught up in implementation. So for you to study this early on is actually, incredibly impressive. And I also just want to mention how I love your figure one and the little and the figures in figure one and how cute that is. So it's really great. And I also love this idea of having the providers being a control for themselves. My question is this resident confounder, right? Can we really, are we ourselves as hospitalists the same hospitalists when we are with residents or without residents? Can we truly just isolate POCUS as the only difference, right? I think for myself, I know that residents keep me honest, that I behave perhaps slightly differently when I'm with residents, when I'm with not, and I don't know if this impact can truly be accounted for, right?
Yeah, it's a super good question, right? So those of you who have the figure one in front of you, whether it's on the visual podcast or in a piece of paper in front of you while you're listening to this, you can see, right, Athena's owl there, right? The filled in one, right? That's the educator. The empty white one is the non-teaching attendings. You can see the little graduation hat. That's your learners are present. And then you can see the ultrasound waves coming there, whether ultrasound was present. So if you look at analysis one, which was just saying when ultrasound was available for a patient stay versus not available, you see the not available was the teaching attending. The available was the teaching attending plus the residents plus the ultrasound. So if you're going to try to isolate just little sound waves, okay, just the ultrasound, you have to account for the graduation cap, right? Or the learner presence. And quite interestingly, 25 to probably 30 years ago now at this place, we studied the impact of residents on patient care, right? It's long been thought that residents have a negative impact on length of stay, on all of these things, right? And that's quite the contrary, actually, at this place. And I think a lot of places know that. Reimbursement is tied to the opposite, so I don't know that it's always made obvious. But we've known that residents improve outcomes in patient care and in system metrics for 40 years of this training program. So we knew if we were going to do this, that we 100% had to get rid of that extra benefit that was present with that owl with the hat on with the ultrasound to get anywhere close to isolating ultrasound. So the resident confounder, which was controlled for, was established by looking at patients from hospitalists with residents and without residents before ultrasound, okay? And it's not perfect, right? It's a different time frame. But it established what we've known for a long time, right? And had looked at previously a very similar sort of benefit to these things, like length of stay, like cost for attendings when they're taking care of patients with residents, meaning the same attendings, right? Just whether or not they had on their teaching hat that week or not. So all of these outcomes, if you had gotten rid of the resident confounder that was controlled for, would be increased from where they are, right? The cost savings would be more for ultrasound, right? All of these things, length of stay reduction would be greater if we hadn't done that. So the resident confounder here may be counterintuitive to some listeners, right? Actually decreases the magnitude of assigned benefit in the outcomes to ultrasound, and it should at this place. We knew that was gonna be something honestly we had to control for.
Got it. I have one follow-up question about study design. The choices you made about some of the outcomes, as Trevor mentioned, were at the time, the outcomes of interest, still outcomes of interest. I'm just curious if there were some, parameters that might have been looked at, having done the study, now that looking back, you may have included. I don't know if it's just stuff that is come into under scrutiny, like maybe in terms of heart failure admissions, renal replacement therapy, or just other, the sky's the limit. Clearly, there are a lot of things that could be studied, but I was curious why you ended up choosing the, radiology cost or length of stay. I think those were really big for hospitals at the time. But looking back on it, are there other parameters that you'd look at, in future studies, or just how did you choose the ones that you did?
Yeah, I mean, I think cost is just the obvious one. This was a different take than patient benefit, right? It was cost. And it was in large part because of questions we got early on that were like, but what's the cost, right? I mean, even back in 2008, that was a question from leadership was, what are we spending on this and what are we going to get back? So that question still today is there. So it wasn't that was any sort of foresight, Tanping. That was just, hey, we got that question. Knowing that a huge driver of cost is length of stay, right? The largest driver, that had to be a very close primary outcome, secondary outcome to the first. And then I think where it starts to divvy up is the question of what subgroups, right, might you look at in your place if you were going to do this, right? And quite honestly, the reason I chose subgroups to prospectively include in this was because I didn't think we'd be able to show much of a needle change, right, for total cost, right? There's so many things in that. And I said, all right, if I end up at the end of this thing and total cost is different, but it's not statistically significant, right? What am I going to fall back on after tons and tons of work here? And I said, all right, well, if I think just through my clinical hat, what patient populations have the biggest outcome today for ultrasound, it's a lot of cardiopulmonary ultrasound here. So it's heart failure patients, it's pneumonia patients, and then it's kind of fluid volume status stuff, right? In the hospital, which is this acute kidney injury sort of, how can we get your kidneys happier, right, faster? So it was those three subgroups that are in this study. So acute kidney injury, pneumonia, and then heart failure patients that were chosen, just based on kind of what you make an impact on day to day. I think I would dive deeper into those if I was doing it again today. And whether I would add some hypotensive shocky sort of category, I think would be my fourth category if I was redesigning this today, was because I think there's a huge benefit there, right? And there's obviously overlap, but that's what I'd add.
Awesome. Tanping.
Just piggybacking on this question about outcomes, I wonder if you had an audience in mind for this paper, right? It sounds like from the very get-go, you had great support from leadership. Sounds like that's one of the key ingredients in getting a program off the ground. But it almost seems like reading the outcomes that is the audience that you were intended for in leadership. And who did you have in mind when you designed these outcomes, when you're choosing these outcomes? And how do you foresee this paper being used going forward, right? After it's published, who's going to use these outcomes and papers and for what purpose, right? Because I can't help but think that people in this chat or people who use POCUS, this is like, well, of course, it's obvious. And is that your intended audience? And who did you have in mind? And how do you see this paper being used?
Yeah, I'm going to do what the intended audience was, and then we can jump to some results, and then we'll take the results and we'll say, how's this going to help people going forward? How about if I do who was the intended audience? It was who you think it was. It was leadership. It was C-suite. It was convincing, right? The dollar holders. And yes, it was enabled here early on and people were on board. I knew that at some point, someone was going to ask the question 5 years in when I said I need 16 new machines, right? What's it look like, right? What actually bigger picture? is this piece. So yes, up front, there was innovation sort of energy that drove the we'll give you money. I knew that new thing, dollars, wasn't gonna be present for the next 15 years. So it was still who you thought it was going to be, Tanping, even though we had, luckily, that at the beginning.
Yeah, Dave, I'm interested, using that as a pivot sort of to these results section. I think, we can all read and sort of summarize what the results are, but I'm interested in sort of the Dave Tierney, high level, if you could say 3 sentences on what the results were, what would you include?
Yeah. So table 2 starts with length of stay, which is not the primary result of this study, okay? But it's positioned in row 1 for a reason on this table, because it impacts the primary outcome, all right? Length of stay in patients who had ultrasound available for their hospital stay was 5.77. And for those without ultrasound available, it was 6.08. Okay, so that's a 0.3 days difference between the two groups, right? Shorter in those with ultrasound. The p-value on that is 0.14, right? And we don't need to talk about p-values, but it doesn't mean that that's not something, right, that ultrasound is playing in. So you have to understand that there was a 0.3 difference between the two groups before you go on to interpret the primary result of total hospitalization cost, which was $4,000 less for a hospital stay in patients who had ultrasound available for that stay. And if you said just on a day-to-day basis, right, not the whole hospital cost, but day-to-day, what was it? It was, $750 less. That seems like a lot, okay? I am the first one to say, man, that kind of seems like an overshot, Dave. And when you say that, the first thing you got to recognize that this is one of the few studies that looked at both fixed and variable cost. And we don't need to go deep into cost here, but so many studies today look at just variable cost difference between two groups. This was inclusive of all hospital fixed costs for a hospital stay as well, which is why that magnitude in part seems bigger, I think. The second piece to that is that length of stay is part of this, okay? Length of stay was not controlled for. And the reason it wasn't controlled for in this first analysis was because I think ultrasound actually decreases the length of stay, right? I think all of us who do it kind of know that on an individual patient level. So I didn't want to take out and control for length of stay between these two groups because it was potentially an impact of the outcome. However, I don't know that all of the length of stay difference, namely the third of a day, which is an expensive third of a day, was all because of ultrasound, okay? So I think when you look at the first set of outcomes, total cost, the savings in ultrasound present, I think it's an overshot of truly in the end, right? If we're being totally honest, what does ultrasound save? I think it's an overshot. So what we did to give ourselves an undershot, all right, a different lens of this was to say, all right, take length of stay out. Now control for length of stay between the two, acknowledging that maybe you're taking out a benefit of POCUS here, okay? But take it out and see what happens. And the numbers in analysis 1B, right? The hospitalization difference goes down from $4,000 to whatever, $1,500. And the per day cost doesn't actually change that much, right? But when you take out length of stay, the total hospitalization costs go down. The per day costs don't change that much. They go down as well. So why is that? And why might it make sense? I think it is, right, about this fixed and variable thing, right? That the cost for a hospital stay is not the same on day one, right? When you order 30 tests and et cetera, as it is on day 4 when the patient's hanging out, right? And there's a hemoglobin ordered for tomorrow. But the fixed cost actually is the same on all those days, okay? So when you do this, you are taking out that fixed cost from the equation. And that I think just supports that what's left here is probably a little bit of an undershot because it's giving no value to savings in length of stay. But it's still a meaningful number as an undershot of $1,500 for a hospital stay. So this is meant to give you two uprights, right? And I 100% will not tell anyone that $4,329 for a hospital cost is for sure ultrasound, right? And I will not tell anyone that the most ultrasound does is $1,500 for a hospital cost. But I'm really, really confident that somewhere in between is the truth. And I think both uprights are meaningful, especially when analyzed with that second analysis.
Amazing, amazing. I can't wait to listen to this podcast so I can fully process all of the insight that you have to these results. One thing I wanted to follow up really quickly was about the chest CT. So I know that you sort of concluded that there was a slight increase in chest CT in POCUS available, category, and that you attributed to like actually clinically indicated follow-up imaging after POCUS findings, either at the start of the study or as you were doing the analysis. Is that something you like you expected? Was it I mean, you were clearly looking at chest CT as one of the outcomes of interest as a costly tool, something you thought that maybe your hypothesis was that POCUS would have reduced chest CT. So curious if you could tell us a little bit more about that or how that played into cost.
Yeah, right. So radiation reduction is a goal, right? A goal for everyone. Ultrasound is a tool to help you reduce radiation-based imaging, and a cheaper tool compared to a lot of planar radiation-based imaging. So the idea of looking at it was not anything more than just it's part of a goal, right? The key, which we all know who do this day to day, is that no question we do less chest x-rays. All right, there's no question in a robust program that you're doing less chest x-rays. So that was going to be a gimme here, especially in, let's say, a heart failure population or something, right? It was going to be less. So what we saw was a 0.24 chest x-ray per hospital stay reduction in the group that had ultrasound available. So there was a 0.24 reduction in chest x-rays. What we saw balancing, if you will, on the other side was a 0.07 increase in chest CTs. All right, both of those are statistically significant. And they're real, I think, both anecdotally and from a study standpoint. So the reduction in chest x-ray is fine. We don't need to go into that. It's quite obvious, I think, to everyone that does this. Why the increase in CTs in the setting of decreased chest x-rays is important. I think our usual workflow here is if you've got a patient and you're pretty darn sure there's something in their lung parenchyma, and you do a really good ultrasound exam on them and you don't see anything, the next step for us is hardly ever a chest x-ray, okay? Because we know that after a really thorough lung exam, the chest x-ray is going to be a waste of money and radiation, usually. Not always, but usually. If you got something that's deep, right? It's bordered by air, and you're not going to see it with ultrasound, and usually not with chest x-ray. So our usual next step is to CT in the setting of negative ultrasound for lung pathology with a good study, rather than chest x-ray and then CT for patient care, cost, et cetera, sort of reasons. So we expect when we use ultrasound that we're going to do a little more CT as a general statement. I think the other thing that everyone out there who is putting this into their place and thinking about studying this needs to know is that without question, there's a referral bias for formal radiology-based and echocardiography-based imaging when you start a program up, okay? You see abnormals, you see normal variants, and teasing between the two is difficult, right? Early on in a program. So in our program, we saw an increase, right, in referral testing the first handful of years. That comes back down to 0, and then it goes below 0, all right? But in the first years, you're going to see that go up either way. So those two reasons, I think, Jamie, are the answer to why more CTs.
Just to unpack that for our listeners, that's not in the study results, the trend towards additional imaging, and then that
No.
faded. You're commenting as advising programs that are starting, they're going to find incidental findings, anterior fat pad. I can't tell if it's a pericardial effusion. I'm trying to think of some other examples that come to mind for why they may have an additional initial referral. Some of the I don't know, Chiari network, just normal anatomic variants you mentioned that might prompt additional testing just to,
Yeah,
for
looking at the stomach, right, on a lung ultrasound and thinking you got a pneumonia and getting a imaging test, all sorts of things, renal cysts, right, that just show up whether or not you're looking for them, right, when you're looking at kidneys and bladder, and you don't know, is it meaningful or not, and you order a formal ultrasound. So yeah, a whole lot of ways that happens, but it's for sure real, and it's not in the paper. It's just 15 years of doing this and watching the trend happen.
Dave, I wonder if you think the results that you have on this study are reflective of the age of your POCUS program, right? So if you were to rerun the exact study now, 20 years down the line, with a very different group of faculty and residents, I wonder what you think the results would look like.
Yeah. So first of all, I couldn't, because all of our hospitalists do this now. So I couldn't do it, which is, again, why this study period was important. Two, I think we're way better at what we just talked about, right? We're way better at recognizing normal variants and not needing referral imaging for as many things. So I think that would go down. I think there's a lot of other impacts today on length of stay, right? I mean, if you're thinking about trying to study length of stay today, and I mean, I've got people hanging out here for multiple days because it's a nursing home bed, right? That wasn't the case then. So length of stay as an outcome is super, super, super tricky, period. It's super, 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 super tricky in 2023, post-pandemic, et cetera. So that outcome alone, I don't know what it would do. I don't think we'd be able to show anything today in that piece. And cost, therefore, from a fixed cost, which is immediately attached to length of stay, right, becomes tricky as well. And you really have to probably isolate variable costs if you were studying cost today for those two reasons. But I think we're better at it. And therefore, if the hypothesis is that the better you are at this, the more you save, I think that probably would be true today. It's just tricky to tease it out.
Amazing. I mean, I think when you look at this study at face value, read the abstract, you put it in your boss's, holiday gift this year with a sticky note that says, please factor ultrasound budget into 2024's, calendar year. I think that, the idea that outcomes, study that's as well done as this, could show a reduction in hospital cost, radiology cost, and chest x-rays, I think is really neat. And I think the listeners can go to page 184 of the November issue of the POCUS Journal to get all the details from the tables. But I think just in our time remaining, I really want to talk amongst this group, what are the implications of this for the field, not just in internal medicine, point of care ultrasound, but in, other disciplines? What are the implications for the healthcare system? What are next steps? What are some additional questions? And I mean, Dave, what are your thoughts that you want our listeners to come away with, and how they might use this and interpret it?
Yeah, I guess I mean, my hope for this as a holiday, a Hanukkah or a Christmas present, right, or whatever, to people is that we all of us who do this, right, know that it makes a difference individually at the bedside, day to day. All right, there's no question about it for patients. All of us struggle with convincing that the bottom line, right, is also benefited by this. That's not anything unique to anyone. It's part of this. So I hope that it just enables some places that clinicians know the benefit, right? Whether that's just personal satisfaction, patient outcomes, safety, et cetera, to be able to use it more impactfully, right? And on a larger scale by having some data that says, and we're not losing money, okay? You can just take this paper and say we're not losing money and it makes us happy. So, or you can say we're actually saving money, right? And it's making us happy and it's better for our patients. So that would be for sure my end goal out of this is yes, that little hurdle is a little lower, hopefully.
Yeah, and Dave, following on that, I mean, I think one of the questions I keep sort of reconfiguring even my thoughts around is just this question of like, how important is research, and I think particularly like outcomes research in internal medicine POCUS prospectively. I think for getting programs off the ground early on, showing the benefits of lung POCUS or that hospitalists can do it and not harm people in small areas was really impactful for me, and I think other people building programs. But I think now people are kind of voting with their feet, right? Like devices are out there, those companies are, being successful. People are getting ultrasounds and starting to use them. Like, how do you see research playing a role in that going forward? And how important is that versus just doing the work and putting ultrasounds on the ground and running with that?
Yeah. I mean, I think initially, right, the innovation factor wore off here, right? And it came down to something else, right? Whatever that is. And the same thing will happen everywhere, right? Once this is just a stethoscope around your neck, right? That awe factor, or that pass, if you will, to be able to use it will go away. So I think it's essential, though often overlooked early on because of the awe innovation factor that's giving you a pass at the time. So I think it has to be studied. And I think the other piece you alluded to there, Trevor, is that, right, when this is done just by this person has an ultrasound, that person has one, they got theirs there, they're using it like this, that one's using that, right? It becomes almost impossible to track what's actually happening with it. So I'm totally in favor of, despite the benefit of everyone doing their thing with this tool from a patient benefit, to having some centralized organization to a place that tracks everyone, that tracks outcomes, right? And just at least up front thinks about, if this does what we think it is, what are the outcomes that we want to make sure we've got being tracked? And yeah, I for sure don't want people not to use it because of the benefits, but it's got to be consolidated somehow, because everyone is going to need something more than just the wow factor at some point in their journey.
Amazing. And you mentioned, Dave, the harms are specifically assessed here. The length of stay and cost may be a reflection of that if there were harms. What about for a radiologist? I mean, or radiology division or the field? They like that we order radiology studies. I mean, I guess my response would be, don't worry, plenty of x-rays were still ordered. So it's not that it drove it to zero. But what would you say to that? If you show this to a radiology department, should they be scared?
Yeah. So, so yes, I think the answer to the question is complex. It is that if you looked at echoes, right, we didn't decrease echoes by that many. And in reality, we don't, right? We get a look at an LV systolic function when someone's got hypotension, and we make sure they don't have a big pericardial effusion. But often there's still a formal echo that happens in those situations, right? So that piece aside, from a non-cardiology imaging standpoint, when you look at the breakdown of the studies that were done in this set of patients, it was 75% pulmonary and cardiac. All right. Radiology shouldn't be real concerned about pulmonary stuff, because really the only thing you're reducing are as they know, right, low sensitivity chest x-rays. Cardiac, we just talked about. So the lion's share of what's getting done, I don't think really impacts radiology. In the abdominal section, which is about a quarter of the studies done in this, that's by and large inclusive of ascites, yes, no. In acute kidney injury, right? Is your bladder full? Do you have hydro? Do I need to put a Foley in you? And those pieces just aren't really on radiology's map as far as impactful, right? So I think you can take that pie, which is figure 2, right, and say, here's what a really big implementation looks like in a hospital setting. Here's the breakdown of the pie, and what part of this are you concerned about? Okay. And really support that argument with the pie and with the outcomes that the study shows as well.
Outstanding. Well, I think that's the time that we have. I really can't thank you all enough for joining today. You're so busy, as our listeners heard from your intros. All the work that you do we're really lucky to have you, Tanping and Trevor. I really can't thank Dave enough for conceiving of a study like this, for conducting the study with data analysis throughout a very long study period, and for taking the time to analyze the data and really report this. It's really a late-breaking innovation. I think it has tremendous implications for programs across the country and really across the world. And the study is available on POCUSjournal.com, page 184 of our November issue. The Association of Internal Medicine, Point-of-Care Ultrasound with Length of Stay, Hospitalization Costs, and Formal Imaging, the Prospective Study. So Dave and your study team, thank you so much.
Thank you.
Yeah, thanks very much, Jamie.
Good.